wabarakatuh, and good afternoon to all. So my name is Dr. Muhammad Izzat bin Johari. I am Cardiology Fellow, currently working at IJN. So the topic given to me is how to approach bradycardia ECG, do not pass out. So without further ado, let's continue with the presentation. So this one is my outline of presentation. We start with the bradycardia recognitions, management of bradycardia, and also the case illustrations. So first thing first, we need to have a clear definition what is bradycardia. So by the National of Health Institute, they had defined that bradycardia is condition where our heart rate is less than 60 beats per minute. So sometimes it can be considered as a normal in specific conditions such as a well-conditioned athletes or in young individuals. Okay, so this one, the image that I shown in the presentation basically is implicate is the analogy of our heart. So in house we have the rooms. It's like our cardiac chamber, separate by the wall. It's like our ventricular septal wall or intra-atrial septal wall. Also in the house also we have the piping system. It's like our coronary artery as well as our venous system. And the last one is that in our house we also have the what we call electrical conduction system. So basically the main switch in our house is like our sinus node. So followed by is a second switch like our AV node. Then there's all the wiring that have been provided to the electrical conduction to our house. So what will happen? We have problem with our main switch, or we have problem with our SA node. Basically our house will be blackout. So patient might complain of syncope, pre-syncopated, or any SSL dysmenorrhea. So so we go to back our main business. So this one is what they call electric system of our heart. Here we can see that this one is what we call SA nodes, and connected to the AV node, which the internodal tract which is divided into three, at the anterior internodal tract, middle internodal tract, and also the posterior internodal tract. And then also is Bushman bundle that connect to the left atrium. So we had the His bundle divided into left bundle branch, right bundle branch, as well to the distal Purkinje cell. So here we can see that the connection is very fast, and then also it must be synchronized to make sure that all the mechanical conduction in the normal ways. Okay, so I will start with the first. We start with our main switch of the heart, SA node disease. So SA node is located at the right atrium near to the SVC. So it can be presented many ways, but the four components of the SA node disease it can be presented with. Number one, sinus bradycardia. So basically, the sinus bradycardia is it can be considered as physiological. It's a condition where we have a sinus rhythm, but our heart rate is less than 60 beats per minute. It can be found in specific situations such as in a well-conditioned athlete, young individuals. And so it also can be related with the drugs such as a beta blocker as well as a calcium channel blocker. Most of the patient will be asymptomatic, and it's a benign state of the sinus node dysfunction. Second presentation of SA node disease is that sinus pause. So what is a sinus pause? So basically, sinus pause is a condition where it's absence of sinus speed with more than 2 seconds. So many of the trials have been shown that if the sinus pause is more than 3 seconds, it considered as pathological. It can be consequences of the sinus arrest or sinus atrial block. And if patient is symptomatic, it might need a permanent pacing. And the sinus pause is likely due to the sixth sinus syndrome or sixth sinus node. The third presentation of SA node disease is tachybrady-arrhythmia. So basically, if you see from my slide, there's a ECG strip that has shown there's a alternating of regular, or it can be also irregular, of atrial tachyarrhythmia. So here we can see that it's a burst of the tachycardia followed by the sinus pause. And it depends how long the sinus pause is, depends on how good or how bad our sinus node disease. So if our SA node is very bad or very severely diseased, after the burst of tachycardia, our SA node might need take a longer time or duration to start again the cycle of the or start the impulse again. So it's due to what we call when the tachycardia occur, it can suppress the SA node atomicity, and the duration will be variable based on our SA node disease. the fourth presentation of an essay note is chronotopic incompetent. So here we can see that the what is a chronotopic incompetent is a represent failure to reach 80% of expected heart rate reserve. So heart rate reserve can be defined by we just take our maximum heart rate, such as we took the, let's say our patient age is 20 years old. So 220 minus 20, and we minus the resting heart rate. So we got if the resting heart rate is 60, so our expected heart rate will be 140. So if we stress out the patient, put patient on treadmill, we expected in the normal people, they are able to reach at least 80% of the expected heart rate reserve. So let's go with the case illustration. We will start with case number 1. We had young chap, 28 years old police officer. He had came for yearly health checkup, and during the checkup noted is bradycardic. So from here, they refer to us for further evaluation IV pacemaker implantations. Baseline investigation turned out to be all normal. Echocardiogram structurally normal heart. So this one, the ECG have been done during the clinic visit. If you can see, it's quite a normal ECG, and you can see that there's a normal axis. The PR interval is normal, and then QT interval also normal. As said, we can see that there's a sinus rhythm with a heart rate of 50 beats per minute. So basically, it's just a sinus bradycardia in a young male. It can be also normal. Plus, patient is asymptomatic. So what's next for this patient? You got 28 years old police officer, asymptomatic sinus bradycardia. So you want to proceed with stress test, or do the Holter, or you want to go more invasive. You want to do the loop recorder to have a longer telemetry monitoring, or you can advise for reassurance, TCA 6 months, and then do nothing. So we choose the Holter as part of the investigation. The reason is that because of the nature of work itself, patient is a police officer, and as part of the what we call the health checkup every year, we need to have proper evaluation before we say that it's a normal study for this patient. So this one is a Holter that had been done to this patient. So here we can see that down there, actually the average heart rate for this patient is roughly around 60 beats per minute. As said, towards the end of the Holter monitoring, we can see that there is presence of sinus pause occur at 6:15 a.m. in the morning. And the duration of sinus pause is about 3 seconds. And when we ask this patient what really happened during the 6 a.m. in the morning, basically patient is sleeping during that time. So asymptomatic sinus pause means surgery normal heart. So what next for this patient? Yeah, definitely we can just continue the observation first, because in asymptomatic patient, sinus pause we can observe, and then we can see back in the clinic. So we start with the case number 2. Now we have different type of patient. First we got young patient. Now we got the elderly patient, 60 years old female, intermittent palpitation and dizziness. And here we can she had one history of syncope with a wrist fracture before this. And this is the ECG that have been attached to the referral letter. Almost the same with the first patient. We can see there is a sinus bradycardia, not much of significant changes in terms of ST segment, QT interval, axis, everything is normal. So, in view of patient had a history of very suggestive of symptomatic bradycardia, so we had done the Holter, and then if we go through all the Holter, basically it's quite a normal Holter. Basically, they had low burden of PVC, about 0.05%. Baseline of heart rate of 54 beats per minute, a bit on the bradycardia side. But you can see the minimum heart rate is occur at night, 55 beats per minute. And it's occur at 1 a.m. in the morning. And no pulse and no tachycardia in the Holter. So if then we look through in the Holter, basically it's just sinus bradycardia, and during that time patient is sleeping. So it's just sleep-related tachycardia is symptomatic. So we were puzzled, what's next need to do for this patient? Because history very suggestive, syncope, dizziness, but what we call the symptom is not too frequent. So either you want to go for stress test to look any ischemia related or not, cardiac MRI to look for any structural heart disease, especially in the elderly patient, loop recorder, or you want to do the chorus, basically to route the CAD. So we choose the loop recorder. The reason behind that is that from the history it says it's very infrequent, but whenever patient had the symptom, it's quite, it's quite causing a trouble to the patient because he cannot work, he will be dizzy, he need to rest, and sometimes he need to skip, take the MC because of the symptom, very symptomatic during the event. So this one, we implant, we counsel the patient and we implant the loop recorder. So here we can see that there are multiple episodes of sinus pulse that have been detected during the in the loop recorder, and then one of the events is occurred at 2 p.m. in the afternoon. And when we ask the patient, is there any dizziness, is there any symptom during the event? Yes, patient did complain of a bit dizzy during this time. So we get the different type of the presentation. We have sinus pulse about 3.8 seconds, and it is symptomatic. So in this kind of patient, do you need to implant or not? But it's symptomatic already, or you just to reassure it's just part of the aging process or not? So based on our clinical, we call the guideline, they have been stated that in a patient with sinus node dysfunction, we need to confirm the symptom first and then rule any reversible cause of the symptom. And number two, we need to correlate whether the symptom is related or not with the bradycardia. So our patient, they had sinus pulse, almost about 4 seconds, and dizzy and symptomatic during that time. So definitely in this kind of patient, permanent patient will be class 1 indication. Except then in the first patient, we had asymptomatic. Basically, you can observe, and then permanent patient will be class 3 recommendation for this patient. Okay, this one is the pacemaker implantation. We can see there is a loop recorder there. This is a dual chamber pacemaker. This one is a RA lead. Second is a RB lead. So why we choose the dual chamber pacemaker for this patient? Basically, you want to maintain the AV synchrony. Then it's better to have the 2 chamber rather than the single chamber in this patient. And this one is the ECG pacemaker implantation. Now we can see the spike, A spike, and then also the V-send. Basically, we can see that the problem is SNO. So definitely we put the lower rate at 60 beats per minute for this patient. Okay. So like I said before, in the sinus node disease patient, the most important thing is symptom. So we have symptom. So whether symptom is attributed or not to the sinus node disease is very important or not. Because the patient may have the dizziness, but it can be due to the cervical, it can be to the what you call electrolyte imbalance, it can be due to the hypoglycemia. So you need to have a correlation between the symptom as well as the sinus node dysfunction ECG, such as sinus pulse or any sinus bradycardia. And in the asymptomatic patient, it is harm to us to implant the permanent pacemaker. So it's a class 3 recommendation in asymptomatic individual with sinus node dysfunction. So you must remember that symptom very important in patient with sinus node dysfunction. Okay, now we go to case number 3. So case number 3, we had 64 years old male, hypertension, obese with BMI of 31, referred to us for a pacemaker in view of multiple pulse episode on the Holter monitoring. So in the we got previous hospital, they have done the chorus, then echo, everything is normal. The blood investigation also everything is normal. So they have referred to us whether for second opinion what need to do because they're worried because it's quite a long pause noted in the Holter monitoring. Okay. So this one is the Holter that have been done in the hospital that have referred to us. So I give you time to look and see the ECG straight in the Holter. So here we can see that there's a two type of arrhythmia. Number one is tachycardia, and then whenever you have tachycardia, always remember to look for the rhythm. Is it regular? Is it irregular? So here we can see there is a tachycardia, and then with variable heart rate, you can see sometimes you have 125, 138, sometimes goes to 72. So you get the irregular tachycardia, and then after the burst of tachycardia, Basically, the first rate will be AF, atrial fibrillations, and then after the burst of tachycardia, you can see that it's a sinus pause. And so, like I said before, the tachycardia can lead into the suppression of the SN nodes automaticity. So after burst of tachycardia, SN node will be suppressed, and then in the patient who had disease at the SN node, so SN node will take a longer time to recover again before they start again the cycle of the impulse generation from the SN node. So when we ask the patient, we ask the patient, is there any dizziness? Is there any symptom during the Holter? Yes, there's a patient complain of the dizziness during the Holter monitoring. And the other thing that one of the important is that the timing of the event. We can say that it occur at around 2 o'clock in the afternoon. It's very important because during 2 o'clock is the time that we do all the jobs. Something go to the work, driving, cross the road. It can if you had symptoms within the daytime, is very significant to us to get further history on that. So, what the next plan management for this patient? So, either you want to treat the AF first, because we know that the burst of tachycardia can cause the suppression of the AV node. So you want to start the beta blocker, tackle the tachycardia, then wait and see. Or you want to start the digoxin, because say that you're more familiar with digoxin rather than beta blocker, or you worry of the hypotension and so on. Or you want to treat the reader control by starting the anti-arrhythmia for this patient, like you can start Mindaron, or if the let's say the echo and everything is okay, then start other anti-arrhythmia like Fecnite or Sotalol. And you want to start together with NOAD because the patient is high risk for the stroke based on Chabat score. Or you want to plan to implant the pacemaker straight away. So what your guess for this patient? What your next plan of management? Okay. So in this kind of patient, it's very important, like I said before, symptom. So the symptom is very typical, dizziness, and then the symptom is attributed to the bradycardia. We can see that sinus pause, and during the sinus pause, patient complain of dizziness. So it's a pulmonary pacemaker in this tachybradysendent is warrant. Okay, this one the recommendation for patient with tachybrady syndrome, and the symptom is attributed to the bradycardia. Permanent patient is reasonable, is class 2A recommendation, basically to increase the heart rate and reduce the symptom attributed to the hypertension. So again, whatever the presentation in the sinus node disease patient, you need to get the symptom first, because no point of implanting the pacemaker and then back your mind implanting the pacemaker is not without a risk. It has also had a risk for the implanting because we need to puncture, we need to put the lead, and then risk of infection later on. So and then if we don't have any symptom for that, we do not have any outcome. What the point of implanting the pacemaker in patient with asymptomatic sinus disease? Okay, now the problem start again. Patient refuse for pacemaker. Is there any option that we can offer for this patient? So because he said that they worry of the implanting something into the chest, and then she said that we need to use the hand and don't want to come to the follow-up, difficult for her. And what the other option that you can offer for her? Okay, this one, the paper that have been published in 2003. It's quite some time already. So basically, in patient with with the irregular tachycardia as part of the tachybrady syndrome, basically it's AF, we can offer for catheter ablation. So by treating the AF, by cure the AF, by ablating the AF, we can reverse we can lead to the reverse remodeling of sinus node function after the catheter ablation for AF in patient with the prolonged sinus pause. This it has been proven that because, like I said before, tachycardia is the culprit of bradycardia because the suppression of the SN node after the burst of tachycardia. So by treating the AF, we can get away from the permanent pacemaker. But not all patients will be eligible for this catheter ablation. The few considerations you need to decide before deciding for catheter ablation. Number one is that how long is how long is the duration of sinus pause? Is the sinus pause is too long, so is one of the indicator that the sinus knot is not normal already. So by even though you have treating the AF, treating the tachycardia part, but the sinus pause may or may not occur again, and then later on patient also might need the permanent pacemaker. So basically in this kind of patient, you need to have a weight, benefit and risk, and basically the implanting the pacemaker in the tachycardia basically is what we call the pace and poison. So by we want to tackle the tachycardia, we can poison with the beta blocker, calcium channel blocker or the digoxin as poison to tackle the tachycardia, and we need the pacemaker as the pace, so that the heart rate will be there's no any symptom due to the drug related that we have started for the tachycardia. What we call the pace and poison regime. Okay, so we have finished the first part of the bradycardia. We see we have finished the SNO disease. So we had sinus bradycardia, then we had the sinus pulse, we got the tachybradys syndrome, and we have also the chronotropy incompetence. So we move to the